Good morning, everyone, and I'm going to have a quick discussion today. My topic is how ultrasound has probably replaced the conventional ankle block. Now, I'm very happy and honored to be over here, and I come from the nearby Bangalore. Now, quickly getting into things, we all know the ankle block, a rather popular block used for surgeries on the foot. And it is a block involving 5 nerves: the superficial peroneal, the deep peroneal, the posterior tibial, the sural nerve, and these are all branches that come out of the sciatic nerve. The other branch is the saphenous nerve, which is the terminal branch of the femoral nerve. Now, literature says that the success rate for this block can be anywhere from 89 to 100%. There's a little bit of ambiguity about this. Let's not bother too much with that. Now, there are some inherent problems with the conventional landmark technique. It has been largely described as a circumferential ring block around the ankle. Now, when we do that, putting a ring block in an area where there are really tiny, delicate, fine nerves, we don't know the consequences of an intraneural injection and whether there are any long-lasting effects by doing this. Now, if you look at descriptions, they say that the conventional dose that needs to be used is close to 40 ml sometimes. Now, this is a rather large amount of local anesthetic volume around a very small area. Is this right? We need to revisit that in this year, 2013. And we also know that it requires clear access to the ankle area. If there's a lot of edema, we cannot really go ahead with the block. When we use ultrasound, we involve accurate deposition of LA around the target nerves, or at least very close to it. There is a significant reduction in the volume of local anesthetic, and there is plenty of evidence coming in that you can just do the ankle block with about 15 ml of local anesthetic or even less. And you do not actually have to limit giving the block around the ankle. You can move up proximally and complete the block. As always, there can be problems with ultrasound. These are very, very small nerves that we are dealing with. So you just cannot see it like, the regular femoral nerve or something. You have to have a good trained eye. The descriptions of the ultrasound block in literature are again a little hazy. Some people use a combination technique where they block 2 nerves with ultrasound and the rest using conventional technique. So the descriptions aren't exactly very pure yet. And because of the structure, the circular structure and contours of the ankle, placing the probe may result in a lot of artifacts, and I will show you these artifacts a little later. We look for any evidence on this. Very quickly, once again, there have been some studies on individual blocks, individual isolated nerve blocks around the ankle compared to the landmark technique, ultrasound versus landmark, and the results are very encouraging. The sural nerve, again 94 versus 56% success rate in favor of the ultrasound. Same thing goes with the tibial nerve, 72 versus 22. Strangely, there isn't any difference if you use ultrasound for the deep peroneal nerve block. It improves the onset, but the quality of the block may actually remain the same. Looking at a larger study over 6 years, again from Vincent Chan's group, 655 patients over 6 years, and what they found, this was a mixed technique where the deep peroneal and the posterior tibial were blocked with ultrasound and the rest with the landmark technique. And again, 84 was a 66% in favor of ultrasound. So we do have something going with ultrasound. A little on the negative side, there are studies that says that using low volume may not necessarily result in a long-lasting block. Block onset is much faster with ultrasound, but the duration of the block may be reduced if you use low volume. Now, this may not be a bad thing at all. It depends on how you look at it. Now, I'm going to very quickly go into the scan techniques of how you do the ankle block with ultrasound. Now, you must remember that these are all very, very fine nerves, 1 millimeter, 2 millimeter. They're really tiny, and seeing them under ultrasound can be really difficult. So this is the problem. But the solution to the problem is all the nerves except for the superficial peroneal nerve lie in close vicinity to a vascular structure. Now, if you have a vascular structure next to a nerve, it becomes an easy block. Look at how we all struggle with the sciatic nerve block in the subgluteal area. It becomes challenging because there isn't any vessel around there. If you had a vessel, I'm sure it would have been very easy. But with the ankle block, there are vessels around, so we use this as a guide. Okay, and if you don't even see the nerve, all you need to do is inject around the vessel and you will have a successful nerve block. Now if you look at the, we'll start off with the posterior tibial nerve. You look at the probe placement over here, again between the medial malleolus and the tendoachilles, slightly proximal, and you look for the marker. The marker is the posterior tibial artery. You might find a vein next to it, and you have the largest of the nerves around the ankle, which is the posterior tibial nerve. Now in this particular image, I've used a 50 millimeter probe, so in the same shot you can actually see the saphenous nerve. Now the saphenous nerve is imaged close to the great saphenous vein. So you look for the great saphenous vein near the medial malleolus, and right beside it over there you will see that's the posterior tibial nerve, and you'll see the saphenous nerve. Really tiny, 1 millimeter or 2 millimeter. If you cannot see it here, infiltrate around the saphenous vein. You will get the block going. But the posterior tibial nerve is actually very well seen. You shouldn't have troubles picking it up. The deep peroneal nerve, again the probe position is going to be on the between the medial and the lateral malleolus, and the marker is the anterior tibial artery. Now the nerve usually lies lateral to the artery. You can see the little nerve over there. If you don't see the nerve, don't worry about it. Just inject medial and lateral to the artery. Sometimes there can be anatomical variance, or even the natural course of the nerve is to swirl around the artery, so you're better off injecting on both sides of the artery if you do not see it. The sural nerve, again the landmark is the short saphenous vein. Now we're looking at the lateral side of the ankle behind the lateral malleolus. You look for a really tiny nerve hugging the vein. The superficial peroneal nerve unfortunately does not have a reliable vascular landmark, but what we need to do is look between two muscles. Now we start scanning on the lateral border of the leg, slightly proximal, and we look for two muscles, the peroneus brevis and the extensor digitorum longus. The peroneus brevis can also be identified by the presence of the ligament of the peroneus longus within it, and right between these two muscles lies the superficial peroneal nerve, right there under the deep fascia. Now if you scan more distally heading towards the ankle, you will see that the nerve actually pops out of the deep fascia and becomes superficial right over there. And if you look at the video, you can see that the nerve eventually becomes more and more superficial, and you traditionally block it as field block on the dorsum of the ankle. This is what actually happens to the nerve. It gets very superficial there. Okay, so though I've been a bit quick, if you're going to remember anything today, just remember these landmarks that I'm telling you about. Posterior tibial nerve, posterior tibial artery. Deep peroneal nerve, anterior tibial artery. Sural nerve, short saphenous vein. Saphenous nerve, great saphenous vein. And the superficial peroneal nerve, remember that it lies between those two muscles. It's fairly easy to identify once you've seen it a couple of times. Summarizing this talk, ultrasound application now allows precise deposition of LA to the target nerves with appropriate volumes. Ultrasound allows identification of the nerves slightly proximal to the conventional landmark techniques. Selective nerve blockade. This is what I use the ankle block for. Selective nerve blockade for analgesia on selective areas of the foot, and it will definitely have application in chronic pain for those of you who do chronic pain. And has ultrasound replaced the ankle block? I would like to say that the ankle block has not been replaced, but it has evolved. We have evolved to a more precise, more scientific, a more skillful technique using ultrasound. Thank you very much.